Moving on now to the beta blockers. Beta blockers all either have a yellow or a light blue top, as shown in the top right photo, and they decrease aqueous production through inhibition of norepinephrine stimulation, which in turn inhibits the sodium-potassium pump and decreases CAMP. Beta blockers generally lower pressure about 20 to 30% from baseline, but as discussed previously and as shown in the lower right-hand figure, they have poor nocturnal coverage or poor pressure lowering at nighttime. They can be dosed either once or twice daily. The non-selective beta blockers have been shown to be equally effective with once daily dosing compared to twice daily dosing. When using them with only once daily dosing, it is preferable to use them first thing in the morning to help blunt that early morning pressure rise while minimizing risk of nocturnal hypotension during sleep. Beta blockers come in two doses, 0.25% and 0.5%, both of which have been shown to have similar efficacy and safety profiles. Now, topical beta blockers may be less effective in patients that are already on systemic beta blockers or oral beta blockers. And topical beta blockers can experience something called long-term drift, where they lose effectiveness over time because the response of the beta receptors is affected by constant exposure to the agonist. Also, receptor saturation can occur within a few weeks of starting a beta blocker, causing it to lose its effectiveness rather early in something called short-term escape. Beta blockers are some of the best tolerated medications in terms of their local side effects. Most patients have no side effects or experience only mild worsening of their dry eye symptoms. However, the systemic side effects seen with topical beta blockers can be dramatic. Punctal occlusion can really be you and your patient's friend here in helping to decrease the systemic side effects that they experience. Some of the systemic side effects associated with topical beta blocker use are very similar to the side effects associated with oral beta blocker use and include bradycardia, heart block, bronchospasm, hypotension, impotence, reduced libido, lethargy, decreased exercise tolerance, headache, diarrhea, alopecia, mood changes, somnolence, and changes in the systemic LDL and HDL. Now, it is important to note that even though beta blockers have been associated with an increase in LDL and a decrease in HDL, these have not been shown to be associated with an actual increase in cardiovascular risk. Topical beta blockers can also mask hypoglycemic symptoms and therefore should be used with caution in diabetics, and they can worsen myasthenia gravis symptoms. Now, as mentioned earlier, they can be associated with bronchospasm and as such are contraindicated or relatively contraindicated in patients with COPD or poorly controlled asthma. Taxol and carteolol do have less pulmonary side effects than other beta blockers, and that'll be discussed more on the next slide. Here is a list of the currently available topical beta blockers and their generic names and brand names. All of them except betaxolol are non-selective beta blockers. Betaxolol, on the other hand, is a beta-1 receptor selective agent. And this is important because the beta-1 receptors are found in cardiac tissue, whereas beta-2 receptors are found in pulmonary tissue. Therefore, since betaxolol is beta-1 selective, it is less likely to have pulmonary side effects like those that are seen in asthmatics and patients with COPD. Carteolol, even though it is non-selective, also has some intrinsic sympathomimetic activity. And therefore, even though it blocks both beta-1 and beta-2 receptors and therefore should have pulmonary side effects, it is less likely to have effects on the cardiovascular and pulmonary systems because of this inherent sympathomimetic activity, which is compensating for those changes. Moving on now to our last class of topical medications, the ROCK or Rho kinase inhibitors. And this is Repressor or Netarsudil, which works through relaxation of the trabecular meshwork, leading to increased aqueous outflow. Now, it may also clear the trabecular meshwork of debris over time, and it may also lower episcleral venous pressure. It also has a component which blocks the norepinephrine transporter called NET, which leads to decreased aqueous production as well. Similar to PGAs, this is dosed once daily and therefore is very convenient for patient use. In the pivotal ROCKET trials, which investigated this medication, Repressor was shown to be non-inferior to timolol and had about 20 to 30% pressure lowering. However, this was 1 point less than latanoprost. Repressor does have some unique reported side effects. It has a high rate of conjunctival hyperemia, rates of which vary depending on the source, but most people who experience the hyperemia did grade it as mild. Patients may also experience conjunctival petechiae, as shown in the bottom right photo, as well as installation site pain, and corneal verticillata, which is shown in the top right photo. Though it is important to note that this corneal verticillata, though prominent on exam, has not actually been associated with a decline in vision. Now, there are also combination glaucoma drops, which are exactly as described, a combination of 2 or more glaucoma medications into one bottle. Now, this is by no means a comprehensive list of the combination agents that are available, but it is a list of some of the more commonly used combination agents in the United States. 2 of the more common ones, Cosopt and Combigan, both have a nice dark royal blue top that patients can identify. Rocklatan and Simbrinza, unfortunately, both have white tops, and so can get a little confusing for patients. One of the benefits of combination glaucoma drops is that you're delivering 2 or more agents in one bottle, which theoretically can increase patient compliance by making it easier for them to use. Also, for some patients, these fixed combinations can actually be less expensive for them than buying more than one bottle or separate medications. Moving on now to our last section on the systemic options for pressure lowering and glaucoma treatment. The 2 most commonly used systemic medications for pressure control are acetazolamide, also known as Diamox, and methazolamide or Neptazane. These are both carbonic anhydrase inhibitors and therefore work just like the topical carbonic anhydrase inhibitors we discussed previously. Acetazolamide is more effective at lowering pressure than a topical carbonic anhydrase inhibitor at about 29% versus 17 to 20% pressure lowering respectively. But about 50% of patients cannot tolerate the side effects of acetazolamide and therefore have to discontinue use of the medication. Acetazolamide is also metabolized by the kidney, and therefore caution should be used in patients with either acute or chronic kidney disease, or dosing may need to be adjusted based on the patient's kidney function. Methazolamide, on the other hand, is longer acting but slower in onset than acetazolamide, and it tends to be better tolerated and have less severe side effects. Methazolamide, though somewhat metabolized by the kidney, is primarily metabolized by the liver and therefore is contraindicated in patients with liver disease or cirrhosis. As for the dosing, acetazolamide is dosed in one of 2 ways, either 250 milligrams dosed 4 times daily, or you can use the sequels or the longer acting acetazolamide, which is dosed 500 milligrams twice daily for pressure lowering. Methazolamide is dosed 50 milligrams either twice or 3 times daily. As mentioned previously, the side effects of these medications are what often limit their use. Methazolamide, though, does tend to have less severe side effects compared to acetazolamide, but the side effects can still occur. It is important to remember that both of these are carbonic anhydrase inhibitors, and therefore they are sulfa derivatives and should be avoided in patients with sulfa allergy. They can also cause fatigue, malaise, hypokalemia, metabolic acidosis, blurred vision, paresthesias or tingling in the hands, feet, or face, gastrointestinal upset, depression, and a metallic taste in the mouth. More serious complications include increased risk of sickling and sickle cell anemia, aplastic anemia, Stevens-Johnson syndrome, and kidney stones. Though kidney stones only occur in about 1 to 2% of patients, they are more common in patients taking bicarbonate. Because both of these medications are metabolized by the kidney, extreme care should be taken in patients with chronic kidney disease. Often, if you need to use these medications in those patients, the dosages need to be changed or renally dosed, in which case the patient's nephrologist or primary care doctor should be involved. Acetazolamide is also less effective in patients with kidney disease. It's only about 50% as effective in patients with kidney disease as it is in patients without kidney disease. Methazolamide, as mentioned in the previous slide, is primarily metabolized by the liver and therefore contraindicated in patients with liver disease. Even though acetazolamide is not metabolized by the liver, it is also contraindicated in patients with liver disease or cirrhosis because it leads to decreased ammonia clearance and therefore puts the patient at higher risk of developing hepatic encephalopathy. The final group of medications that we'll discuss are the hyperosmotic agents, of which we include mannitol, glycerin, and isosorbide. All of these agents lower pressure by decreasing the volume of the vitreous. However, because of their associated adverse events, as well as the relatively short period of time over which they act, they are only indicated in emergent cases and should not be used chronically. Some of the associated adverse events are headache, confusion, backache, myocardial infarction, electrolyte imbalances, renal failure, precipitation of congestive heart failure, and intracranial hemorrhages. The first of these medications that we'll discuss is mannitol. It's administered either as an IV push or as a drip over about 20 to 30 minutes. It's dosed about 1 to 2 grams per kilogram IV, and it onsets within about an hour and lasts up to 6 hours. But again, because of these associated adverse events, it should really only be reserved for use in emergent cases. Glycerin and isosorbide are 2 additional osmotic agents. Both are dosed 1 to 1.5 grams per kilogram and are administered orally. Glycerin achieves its max IOP reduction within approximately 30 minutes of ingestion and lasts about 5 hours, but can cause some serious metabolic disturbances, especially in diabetics, and therefore should be avoided in diabetics. Isosorbide, on the other hand, is a little bit safer for diabetics, and it achieves its peak effect within 1 to 2 hours and lasts about 3 to 5 hours. Congratulations, you've made it to the end of this lecture and therefore are rewarded with one of my favorite glaucoma cartoons. But in all seriousness, I hope this lecture was helpful to you. Please feel free to email me with any questions or concerns or just for any reason at all. My email address is listed at the bottom left of this slide here. And I hope you all have a great rest of your day and thanks for listening.